Okay, thanks very much. Actually, the first part of this talk has been already summarized by the NIH colleague, and so we'll jump to the next section, to the next part, which is the study that precedes these two studies that were performed at the NIH and at our center, and it was the study by the Paris group. The study performed in 2009 by Julien and colleagues included 37 patients with ECD. They were studied with CT or MRI, and the percentage of patients who had abnormal heart imaging findings was 70%. The majority of them had right atrium involvement and involvement of the atrioventricular sulcus. Of course, they had also pericardial involvement and pericardial thickening. And there was peri-arterial infiltration of the coronaries, of the left coronary artery in about 1/4 of the cases, and of the right coronary arteries in the cases with the atrioventricular sulcus infiltration, and also in other patients. So actually, this was kind of a warning: be careful that these patients do have an important cardiac disease. And a very important message that came from other studies as well was that cardiac disease is an adverse prognostic factor for these patients. So the consequence of this is that most patients with cardiac disease, even in the pre-BRAF era, they were treated very aggressively. Usually also the Paris group tended to raise the dose to 6 or 9 million of units of interferon alpha. So this has implications actually. So in our study, we aim to assess the frequency and type of cardiovascular manifestations in ECD using a standardized cardiac MRI and angio-MRI protocol. Also to compare the outcome in terms of overall survival and progression-free survival in patients with cardiac disease versus those without cardiac disease. When I mean cardiac disease, I mean lesions that were detected by MRI, which may not necessarily be the same as symptomatic lesions as they were considered in previous studies. And then to explore also the extent of organ involvement in patients with and without lesions, because it is not known whether the adverse prognosis that these patients had was the result of cardiac lesions per se, or was the consequence of a higher disease burden. So we included patients in a prospective observational study where we used the same protocol, and the 23 patients were enrolled in an 8-year period. Diagnosis was made following the vestibular criteria, and of course no patient had to have contraindications to the use of gadolinium medium. This was the MRI protocol, and we used a 1.5 Tesla scanner. The acquisition was ECG gated for the heart lesions, not ECG gated for the large vessel lesions. And we used different sequences as well as the NIH study did, using sequences to evaluate the morphology and also the kinetics, so the function of the heart, and also to assess delayed enhancement, which is a sign of tissue infiltration, tissue fibrosis, or inflammation. And so this is about 10 to 15 minutes after the injection of contrast medium. So the 23 consecutive patients enrolled, 20 of them were male. The median age of diagnosis was 48 years. 16 of them were enrolled in diagnosis, so in the majority of them, the lesions that we see at MRI are the lesions at the time of diagnosis, whereas 7 of them had already been diagnosed a few years earlier. All of them had biopsy-proven ECD, and in 12 of the 18 patients tested were positive for the BRAF mutation. So out of the 23 patients, we actually found only 10 patients, so 43%, who had MRI evidence of cardiac disease, which was in the majority of them both myocardial and pericardial. 7 patients had large vessel disease, and almost all of them, except for 1, had simultaneously cardiac lesions. So the occurrence of large vessel disease was in patients with cardiac lesions. And the lesions that we saw were pretty much the same that others have already observed. But I would like to just focus the attention on a few points. If we compare this disease with other infiltrative disease, this disease doesn't show any signs of diffuse myocardial infiltration. This is a more pseudo-tumor infiltration. So this does not have an impact on cardiac function and contractility most of the times. So this is different for the clinician. For instance, it's a good message if we compare this with other diseases such as amyloidosis or other deposit disease, where we do have a diffuse infiltration. In this case, the infiltration is patchy and is made of masses most of the times. Then another major point is the involvement of coronaries. It has been reported that myocardial infarction may occur in patients with ECD, but in our study, as in the NIH1, the infiltration of the coronary was most of the times asymptomatic, and also if we look back at the clinical history of the patients, they didn't have any signs of ischemic heart disease. These are MRI images where we see this. This is actually the hallmark of the disease of the heart in this four-chamber view MRI, where we see the lesion that occupies the posterior wall of the right atrium and the right atrioventricular sulcus with the encasement also of the right coronary arteries. In this image, we can see that there is delayed announcement of the lesion, and in this projection here, in this view, we can see that there is pericardial effusion, which is the white one, and also pericardial thickening. And pericardial thickening is sometimes not uniform, but it can be irregular and can form these bumps here. You can see these are nodules, and they can be seen here better in this four-chamber projection. These are large vessels involved, and this is the case of the origin of the aortic arteries and the origin and the ascending aorta. In these slides, we see the involvement of the aortic arch, and here the involvement of the periaortic bulb and the coronary origin. This is a video which I think will not work because I tried it before, and I'm very sorry because let's try again. But it doesn't seem to work. Anyway, this video was to show that patients with cardiac disease usually have normal contractility of the left and right ventricular, and even in case of pericardial effusion. If you see these patients had a huge pericardial effusion, and sometimes these effusions lead to tamponade, but most of the times the clinical presentation of these patients is very insidious, is very slowly progressive. So the function, the myocardial function, sometimes, or most of the times I would say, is not affected. Actually, we had one of these cases that went worse after pericardial drainage, because 2 liters of pericardial effusion were drained in a just single session. And here we can see that the picture after pericardial drainage and sirolimus therapy, where we have the disappearance of nodules. We had cardiovascular complications in patients with cardiac MRI lesions and even in patients without cardiac MRI lesions. And we have to underline that some patients also had acute coronary syndromes or ischemic heart disease, which was not ECD related. And it was related to coronary artery disease, so atherosclerotic disease, calcified disease. In terms of survival, 3 patients died over the follow-up, we will show you later. 1 in the cardiac group and 2 in the non-cardiac group. So if the mortality rate was pretty low, and there was no difference in terms of overall survival in patients with cardiac disease and in patients without cardiac disease. And also when we compared the progression-free survival, so the time from stable disease to first progression of death, there was actually no big difference between the 2 groups. But when we compared the frequency of organ manifestations in patients with and without cardiac disease, we could observe that, for instance, endocrine involvement, skin involvement, but also retroperitoneal involvement were generally more frequent in patients with cardiac disease than in those without. So when we calculated, when we tested the difference in terms of number of organs involved, extra cardiac organs, so the heart is not counted in this, we found a statistically significant difference between the 2 groups. And if you look at patients with more than 4 sites involved or more than 5 sites involved, they all fail in the cardiac group. So the conclusion is that the patients with cardiac disease MRI usually have a more disseminated disease, these might account for the worst prognosis probably that was observed in previous studies, whereas our study was not powered enough to detect a difference between patients with and without cardiac disease. So the conclusions are pretty much the same as those observed in the NIH study. The frequency is about 40 to 45% of patients that have MRI detectable cardiac lesions. The typical lesions are the ones that we showed. Patients with cardiac lesions more frequently have disseminated disease forms, but larger studies are needed to assess whether patients with such lesions really have a worse prognosis. Thank you.
Thank you. Just a question for Augusto. Maybe I'll start and add a similar question for Diana. Have you guys done much serial imaging on therapy, you know, the impact on therapy on some of these lesions?
Yes, the study was not performed to be a longitudinal study, but anyway, we did it in 8 of the 23 patients, and actually lesions remained stable in most of them. One of them progressed, and she had a full progression of disease, and 2 of them had a partial response, and they were both on our trial on sirolimus and prednisone therapy. Of course, most of them, 3 patients underwent pericardial drainage, so you think the clinical improvement may also be later on, maybe due to that.
Did you see any important arrhythmias in any of these patients?
Yes,
it was so structural so far with you described.
Yeah, we had a patient with an atrial flutter that was that underwent femoral ablation as well.
But no blocks or any serious things that
no grade 3 AV blocks. Of course, type 1, grade 1 that could be, but no severe things.
One more.
Several people have raised the issue of whether these coronary lesions are clinically significant or not. I just comment that the first patient I ever saw died of an MI at the age of 48. This is back in 2002 before I started doing cardiac MRIs, and at post-mortem he had ECD infiltration around his coronaries. I have a second patient who presented with an MI, and his ECD was diagnosed at the time of CABG and then sent to me. So I think these lesions can cause significant myocardial ischemia. It may not be as common, but I have type 2 that has significant disease.
Yeah, I mean, this is sometimes it's personal experience. I mean, we also had patients with ischemic heart disease, MI as well. But when you judge, even using MRI, our estimation was not just based on MRI. Of course, patients with some kind of coronary involvement also underwent coronary angiography, and they had no lesions that were worthwhile being treated. So I'm not saying that this is not always the case, but I would say in the majority of patients, we might be reluctant to at least perform invasive procedures to treat such stenosis. And I would just behave as if the disease was a common atherosclerotic disease. I mean, I would not do anything preventive for such lesions, unless there is a significant stenosis.
Did you correlate BRAF status with
there was no correlation.
Okay. Thank you. So maybe we can do the coffee break because Karen Courtier is coming. She's in cab coming from the airport, so she will do her talk just after.
Yes.
Okay. Okay.